very good.
Thank you.
Just thinking about healthy populations and primary care, and how right now, like, that's kind of an emerging practice area for us. And I know, like, I have some friends who are working on their clinical doctorates, and they're talking about how can OTs be more employed in primary care. It's hard to get in to primary care, and like, because it's almost like these hospital systems still see us as silos.
Yes.
But you think about how that interdisciplinary team can come together when they see the client in the general practitioner's office or the geriatric physician or whatever kind of doctor you're working with. Why aren't we in that? Why aren't we doing that? That's what I want to know.
I agree. I don't know. I think I oftentimes feel that we are paralyzed in some way by the silos of the disciplines, right? So we're trained with a certain lens. You spend all this time learning how to do what you do from this perspective, and then to say, but we need to bring all of these perspectives to the table to come up with a solution. I just think sometimes it's difficult, it's challenging, right, to kind of get over that hurdle. I know you all have these meetings monthly, and I don't know if you all ever do like a virtual meeting, but Natalie Leland, she is She's a great friend of mine, and she's an OT, and this is her life's work. And so I would say if you all could ever bring her in, or if not, in person, virtually, she is an excellent person. And one of the things that I love about Natalie's work is that she thinks about how do we move the meter on this on this interdisciplinary perspective, and she also incorporates the importance of diversity and aging in all of her OT work and research. And so I think that she is just another person leading the field in this area of how not only we can all come together to solve or to promote better health, but also incorporating the diversity and the importance of cultural competency across the field.
So I work in home health, and I work in 30318, which is, West Atlanta, and
that's a little bit over that way.
and I had read, I guess a couple of years ago, there was this study that the Georgia Public Health Policy Association did in conjunction with the Robert Wood Johnson Foundation on life expectancy per county, and for zip code, and 30318 had the same life expectancy as Cairo, Egypt. And so I took that to the agency I was working with, and I'm not going to name any names, and I said, it's interesting because we're the same agency here that serves 30327, which is one of the wealthiest zip codes in the country, and we also service 30318, and we're treating those two areas the same.
Yeah.
So, I think what we should do is try to investigate, how can we sort of make, our services more, I guess, relevant, yeah.
Culturally relevant, socially relevant, yes.
Yeah.
So, I agree 1,000%. It's interesting because that's one of the reasons that I was motivated and, again, excited to be invited to come here this evening. But one of the things that drives me is not only making sure that older adults are receiving the type of care that they need and deserve, but to really spark the conversation around cultural relevance and cultural sensitivity for subpopulations. And, I use culture. I tend to focus on aging African Americans, but I use the term culture broadly, intentionally, because I think about culture as any category, right, with shared experiences, shared values, shared beliefs, and so that's not limited to ethnicity. That could be a community culture, right? It could be an ethnic culture. That could be a social culture. So really thinking about how we create or think about that cultural lens, I think is important. I think that conversation needs to be continued to be had to get people's wheels turning to realize that this is not a one size fit all, right? We don't just create it and if you, well, the field of dreams, if you build it, they will come. That's not really how it works for aging individuals living in these impoverished, these health uh, communities disproportionately burdened by health disparities.
Yeah.
Like, we can't ignore that these issues exist, and we just have to be more intentional about having the conversation.
Yeah.
And then once we have the conversation, think about what can we do to move the meter at the policy level, at the research level, and at the practice level to really make a difference and change the lives of these individuals. But I completely agree. I do some work along the Atlanta Beltline, and we look at older adults living in the west and southwest communities, and I can tell you that just the health of the individuals in certain communities are very different from those who may live in the east side of the, when we think about the Atlanta Beltline, that corridor, but the east side communities. So just really thinking about those differences and how we can provide the support needed.
But we also need to think about it before they become geriatric.
Oh,
too.
yes.
So this is not just a geriatric thing, because some of those demographic factors they just keep going forward.
Yeah.
So I mean, that's
I agree. I think you are really speaking my language, and Rebecca can attest to this. But one of the things I say about gerontology is, and I did focus my talk on 65 plus, so I guess I'm kind of guilty, but that gerontology is the study of the aging process, right? So it's not about, you don't wake up and you're 65, you don't wake up with 3 chronic conditions, you don't wake up and, you are 100 plus. That's not how that works. There's a day-to-day journey, right, that leads to those outcomes. And I think one of the things that I think about is exactly what you said. I'm doing some research now where I'm interested in thinking about community partners that can not only target older adults, older African Americans, but that can also educate younger African Americans about chronic diseases. I tend to start my work at about age 45 because for African Americans, the diagnosis of chronic condition starts around middle age. And so in order for me to think about management so that there is not this exacerbation of negative outcomes later in life, I need to catch them early on, right, and have these conversations and engage them in resources early on. But one of the things I think about is just this intergenerational perspective, and how do we think about, introducing, whether it's nutrition, whether it's exercise, whatever the case may be, how do we think about that earlier in life so that we really are changing communities and not just changing individuals.
And partnering with other community agencies that deal with things like bringing healthy foods to areas where there's no foods, or safe places for kids to ride their bikes and families to go to the park. It's just, there's so much need.
And I gave the swimming example, but it's true when you tell somebody, if you walk so many minutes a day, or change this one behavior, you will literally see significant changes in your A1C, or you will definitely see these significant changes. Well, what the individual failed to tell you is that I live in a crime-infested neighborhood. So where am I walking? I'm scared to get out of my car and go into the house, right? Or we don't have any sidewalks. People take for granted, well, where am I supposed to walk? Somebody told me once that, they suggested I go to the gym. I don't even know where a gym is. And just to have these conversations, because sometimes you forget because it's not your content. Right, it's not your content.
I don't have the cash for it.
Right.
I'm buying my pills, let alone go to a gym.
Yep. I did. One of my papers coming out of my dissertation, the older adults reported in the arthritis self-management program, and I gave a vignette where they got a hypothetical price of what the cost of participating in the self-management program. But giving them that cost, and I based the cost on essentially the cost of the materials of the program if you were to buy it yourself and engage in it. And the majority of the participants talked about how cost would be a barrier to them participating.
Well, I was just thinking, we're talking older adults, but a lot of the thought process too is a lot of the older adults who were Depression era. They went through a time that none of us could understand. But there was no going to a doctor, because a lot of times if you went, first you didn't have money, but if you went, you died because you were so sick by that time, they couldn't take care of you. And I know it from my dad. I mean, he was like, he would hear a lot of what we would do, and he'd be like, my God, you know, you're spending that kind of money? Because back in that time period, they couldn't do that. And then second, I was thinking, we've never really had the culture of respecting elders. You know, I mean, it's always been, well, even some doctors, I hate to say it, you know, they just, oh, well, she's 90, you know, okay, so just take her home, make sure you give her these meds, she'll be fine. Instead of like really looking at that person and saying, okay, we need to do this. You know, so, you know, that's that cultural part that you were talking about.
And that's why I have the conceptual model kind of pictured in this way, because I that is the very thing. I said, okay, on top of all of these factors, then you have to deal with ageism or other situations that come with being an older adult. So it's not only that I'm African American, I identify as a lesbian, and I live in a rural area, and I'm low SES, but I'm all of that, and I'm 75, and I'm 85. So it's like, oh, I have all of this going on that's unique about me that contributes to how I proceed as far as health and health behaviors. And on top of that, I have the experience of being an older adult.
What, real quick, sorry, this is my second one.
Take notes, Dan.
I'm just the guest.
So I wanted to try to ask this as unbiasedly as possible. What are your thoughts, if any, on like Medicare Advantage plans and how like Humana and UHC and all these different, you know, companies that create these, you know, so-called comprehensive Medicare Advantage plans, how do you think they affect people, you know, in you know, with low socioeconomic, you know, situations and things like that, and minorities and things like that? Do you think it's somewhat helpful, or, you know?
I think there are pros and cons.
Yeah.
Right? And I'm very careful too, so I'm going to be careful on how I respond as well. But I do believe that there are pros and cons. I think anytime there is policy change, anytime there is a shift in administration and governmental spending and funding around health and healthcare, I think it leaves a lot of room for development in some regard. I do feel that with some of the Medicare Advantage programs that there are parts of it that are beneficial. I think when we talk about low socioeconomic status and we start to think about individuals who, I don't even want to say don't meet the cut, but what we have to realize just about Medicare as a whole is the fact that if you are of low SES, there is going to be a point where those services are not helpful, right? They're not making ends meet. You're going to need some Medigap service, right? Whether that is Medicaid or some supplementary insurance or service or programs. And so I think the emphasis needs to be placed on understanding how can we create programs and services that's actually going to fill that gap and meet the needs of those underserved populations.
Yeah.
I'm not sure if that answers your question broadly, but
I hate gym care.
I mean, you know, that's why I said I'm very careful. I try to not get in the weeds. I do. You know, but I do realize, and then you have the challenges with Medicaid and the differences by state. I mean, there's so many things where disadvantaged populations, if we don't make the necessary changes, do not benefit and can easily remain disadvantaged. And I think those are the pieces of those programs that we pay attention to. Do I ever think it's going to be something that everybody agrees on and everybody likes and think that it just works well? I don't really know. But I do think that we can be thoughtful in really thinking about services that support those who are left without, when there's no program to fill in that gap.
I do think it's important to think
about, like the other day I heard something about, and I don't remember the number, like the idea of medical deserts, that a huge percentage of our population still exist in these medical deserts. But what they don't necessarily think about, or what I think we need to think about as professionals, is that might not necessarily be a rural area. It might be the 318.
Right next to Grady.
That's
Right.
that might not appear on paper as a medical desert, but because of all those things, it's like this carrot
Yeah.
that they're not going to be able to obtain. Just like a lot of the programs, sometimes it's so frustrating because it's out there. I can get my patient the tub bench, but they just have to get it. Well, they don't have transportation to get it.
Yeah.
So it's like this breakdown, or with I again heard on the radio this morning that CVS or Walgreens, whatever one of them, delivered medication by drone to somebody's house in North Carolina or something, and dropped it off in the yard. And I'm like, well, that's cool, but what happens when they can't get to the door, or they live in a high crime area where someone's like, oh, cool, here comes the drone of my pain meds that I'm gonna go steal from somebody. There's, again, it's like this carrot. Well, here's your medicine, but you got to be able to get to your mailbox to get it. So, that piece of it, we're not thinking about it in that way. And the other thing that really scares me is, of course, with all the changes that we're experiencing in nursing homes and then in home care, that, like what you said, these numbers are just broad, that we're not taking these things into consideration. So, I think that gap is going to widen, unfortunately, unless, really, really drastic changes occur, even though, there's strong evidence to support for home care. I read that, reduced hospitalizations occur for 80% of the population can reduce rehospitalization if they have 2.3 therapy visits a week. So that's combined PT, OT, speech. If they're reducing rehospitalizations by 80% across the board, why are we talking about cutting those visits? 3 and 4-fold, those numbers, it doesn't make sense. So until I don't know, until what policy changes, it's.
And it's even interesting because I think about, even from a research perspective, oftentimes in an academic institution, so you do the work, you think about the interventions, you bring in the partners, you work with OT, you work with PT, you work with speech, and you have everybody come in and you create what is this ideal intervention that thinks about all of these factors. But then there is the piece of, once you have deemed it evidence-based, once this is an effective intervention, well, it has to be sustainable. So then how do you implement it in a healthcare setting where it's sustainable and reaching those who need to be reached?
Well, and if you look at it from just solely OT, the diversity we have in this room, which isn't really much, is pretty much standard OT diversity in all of OT. The majority of occupational therapists are white, middle-class women, and so those populations do not have access to us because we don't live in their communities. We are not part of their, and I'm not saying that everybody, but that's the majority of occupational therapists. So that piece can't even access us, even though we have a lot to offer. And to figure out a way to bridge us going, accessing those communities is a big chunk of the
Mhm.
problem.
And I think part of it with kind of what you were saying also is like, so when I was in California, I worked in Palo Alto at it was a nonprofit, and we worked with post-stroke people, and like it was racially diverse, but if you looked at everyone that came to it, everybody was a doctor, a lawyer, an engineer, a PhD, like highly educated people. And I kept thinking, even though we had scholarships for people, you know, that couldn't afford to be, you know, that were not self-pay, like how come there weren't more people coming in? And I still don't, you know, I mean, there's various factors, as you said, but it's just so sad that you keep seeing that there are programs that, you know, try to provide access, but somehow it's still not giving access to everyone.
I would like to add as well. First of all, I appreciate your research because you're engaging the population that you see these disparities in. I feel like some research doesn't always go directly to the source, so I think you're getting very valuable data by engaging the source. But like she said as well, many OTs are not in some underserved areas. I personally serve Henry County, Fayette County, and Clayton County, and so just going there, just seeing it, and I live over here in Dunwoody, but just driving down 75, you can see the environmental changes. Some of the patients are only seeing PAs or nurse practitioners. Doctors are seeing 70 patients a day with that model, and so like they're spending 5 to 7 minutes at a time with patients. And like you said, very true. When I was in OT school, it was like 3 black girls.
You're it.
Right, pretty much. And it was just about 45 of us, but you know, we were the face of diversity.
It's not representative of the
Exactly.
population in any way.
Right, and I also want to add, I think it's more so socioeconomic, because even in Locust Grove, even in Peachtree City, Fayetteville, it's not always just Black people, but sometimes you might see individuals of other groups that just, you know, they don't have the income, and so I think it's socioeconomic, because if you live in those areas where there's not many providers, it's just hard to find that access to care. So I think the takeaway, or you asked the solution, I think one thing we can do is realize that classism, elitism is so structural. You get through one layer and it's like climbing. I mean, there's so many systems in place that will kind of just impede the access. And I think too, just engaging everybody, you know, because like you said, many doctors might not be open to us in primary care, but I think that would be a huge benefit to us. Even today, I emailed my mom. She works at a corporate center up here in Alpharetta, but I emailed their director, someone. I said, hey, can I implement a wellness program at your job? I just want to provide information about wellness. And he was like, no, I don't really think that'd be something that suit us. But my mom always complains about how they're just sitting all day. You know, she has back problems. So I'm like, I know there's some ergonomic issues there. So I think it's just being open and receptive, but that's just another layer of the structural issues.
Barriers.
So
There's a lot of barriers right now. The reimbursement systems and
it's so many
the higher level administration, and you know, it's just it's complex.
It's interesting because it is so complex, and I say this, and you know, we had an hour, and so I teach this day in and day out, and a semester long of kind of teasing apart some of these a little, you know, in more depth. But even what the comment that was mentioned about presenting upon crises, that is actually still very relevant in many racial, ethnic, minority communities. Once they seek care, it is at such a point of crisis.
That sometimes it's too late.
Right,
It's
and
too
so
late,
it's just like, okay, well, how do we think about this? Like, how do we consider all of these factors? How do we get to prevention? How do we overcome?
I just want
And
to
a
add
lot
to
of
that.
this- oh, I'm sorry.
I'm
Yeah,
just
go ahead.
really quick. When you said there are people with 7 diagnoses, I usually know when I'm going in, when I'm writing my plan of care, I'm going to document so many diagnoses: hypertension, hyperlipidemia, COPD, CHF, and recurrent hospitalizations. I mean, by the time we can get them good and going, they're back in the hospital. So I was not surprised when you said, oh, 7. I'm like, oh, that's typical.
Yeah.
You know, like,
See, that's a different group, because sometimes I get
I
like
work
a deep
with
sigh, like,
children.
oh,
I work with children, so I'm like, oh my god, we gotta do something with our youth.
Well, I was
Yeah.
also going to say that, with all due respect to any physician, but a lot of the older generation, again, they looked at doctors, and I know my dad, I'm going to use him as the example again, as God. I mean, what that doctor said, and again, and with all due respect, I'm not saying that, you know, in any way, but So you have a lot of these older people going in there, and if that doctor didn't give them any other, or say, it was just like, I told him what was wrong, he told me to do this, and that's it. And, so there wasn't that openness or advocacy like we have now. You walk in there and they say something, you're like, wait a minute, no, I don't.
Let me
how
Google
about-
that real
Yeah, like,
quick.
what are you talking? I
I don't
know. Our generation turns around, we want to know, no, I don't want this pill, or how can I do this? They didn't. I mean, they never questioned a word. I mean, my dad would walk in and go, okay, this is what the doctor said. Well, So I think that's also an issue.
That shows up in the research too, and in a study that I did, one of the barriers that rose in significance was lack of a recommendation by the doctor.
Mm-hmm.
So they weren't willing to participate. You
Because
could
he
give
didn't
them
tell me to.
information about the interventions and where you can reach some additional support, but because there was a lack of recommendation by the doctor,
Doctor didn't tell me how to do that.
no participation.
Do you have a favorite older adult physician, primary care?
Oh, I don't. That's a good question.
We're all like,
I don't because
Yeah.
Could be like, I'm not taking any more medication.
yes, I don't, and I don't even know why I don't. Maybe because I feel like they're so few and far between. I'm just happy to have an opportunity to work with any geriatrician.
But I have older parents, and they say to me they can't even go in to see most doctors because they won't take Medicare.
They won't take the Medicare. Yeah, wow.
Yeah, Medicare, Medicaid.
Mm-hmm.
And one of the things that I'm hoping to do, and with my work too, is to get more. So I did a lot early on, kind of looking at, what are some of the responses? Why aren't we using these resources that are out there? What are some of these unique nuances? But I'm really moving forward toward work that targets implementation, and so really trying to understand the contribution of implementation science. There's a lot of work getting done or being conducted in implementation science. And I will say that they really are thinking about the field of implementation science, really thinking about how can we answer some of these issues, right? How can we bring together these fields of study to resolve an issue? So I'm hopeful, but I think that, again, this conversation has to continue in order to see the meter movement in that way.
And I just see us as people who want people to be participatory and engaged as those people. So we know that we could fill those gaps. We just have to figure out the logistics on how to get in.
And
get
oftentimes
paid.
as researchers,
Yeah.
right, I was going to say something, oftentimes as researchers, again, that goes back to the temporary funding sometimes of a research project or a research
Right.
grant, and then the research is removed and the program is deemed evidence-based.
And
But
then
how
it
do
stops,
you,
right.
how do you get the buy-in?
going.
Where is
Right.
the implementation?
Right.
Where is the
Yeah, because
sustainability?
it's impossible. Sometimes, there's people that go into these emerging areas of practice with grants and things, and the grant runs out, and they're like, well, now what do I do? Because you're constantly having to seek money. It's like exhausting.
Mm-hmm.
When you have to know the questions to ask.
Yeah.
So whether the individual, doesn't necessarily volunteer the information to the
Right.
doctor, or the family members
Right.
don't
Right.
know. So how
Right.
can you advocate for something that
Right.
you really don't even know?
Right.
Like if the government
You're
could just
looking
say to
to-
these doctors, you must have an interdisciplinary approach in your primary care practices. You must hire an OT.
And I think there must, the other thing too I think is missing is oftentimes we don't know a lot about the individual. And you make a point because I don't try at all to put the onus on the system. I don't try to put the onus on like the healthcare system. I don't try to put the onus on the providers, and I don't try to put the onus on the individual. I think it's a collective
System.
that has to work
Yeah.
together because oftentimes people don't disclose why they do or do not engage in certain behaviors or what is a barrier or a facilitator, or the fact that, again, I'm a researcher and I use the term barriers and facilitators. Like, that doesn't resonate with people. Like, what does that mean? Like, so
That's a speed hump.
right, like
Right.
what do you mean? So really just having those basic conversations. Well, we suggested that you do X, Y, and Z. What prevented you from doing that? Why didn't you do that? Having these basic lay person conversations that get us to the point that we're all, hoping to get to as far as equitable care.
I mean, it even goes down to like your swimming example, but again, like even in home care, like if someone, even the OT, and again, not knocking like hospital OTs at all, because obviously
We're all sitting here.
we're all sitting here.
Yeah.
But sometimes there's this disconnect of like, oh, this patient needs this wheelchair, this XYZ in their home, and then the patient, half the time I get there and they're like, oh, I'm like, oh yes, where's your stuff? Where are your goodies? And they're like, oh yeah, I gave it all away because, like the bedside commode doesn't fit in the bathroom and that's our only bathroom and I'm not putting that on my toilet when I have 3 generations living in my house. Well, or they could have used a shower chair instead of a tub bench and now they have nothing and are going to have nothing unless I fabricate the plastic lawn chair because that's what we got. And it's that or nothing. So it's like that breakdown again, because somebody's not going to offer or consider like, oh, hey, yeah, I got a glass shower doors instead of a shower curtain. Tub bench not going to work. Some of those things, or the wheelchair is going to be too wide to get through the interior doors of my home. So I got this great piece of equipment, but I'm not going to be able to use it. Again, like that disconnect of asking those questions.
And sometimes they're the basic questions, right? So again, we can't go in with it, so what was your barrier to not using your chair? Or what was the facilitator? What made this great for you? You got to really change the conversation and just put it at a level where you can get the information that you need. But I also think those types of, we make a lot of notes, and I think we've come a long way with, medical records and, folders and things in the home that keep records of when therapists are in the home. But I think even pushing for a practice of even that amount of communication, right? If there was something that I could go and read and know what somebody else already found out and documented, it keeps from reinventing the wheel and trying to start from scratch and figuring out what you need to do when somebody else has already been thoughtful about it. And then the second piece of that is it keeps that record, and if that can be transferred, say somebody does have to go to the hospital, they do have to transition, back to the hospital. There is a record that we can take that can communicate changes that have been made, things that have worked, things that haven't worked. That's not always, those are the types of things that are not always accessible, but that we will see in some of the behavioral intervention research has been shown to work. Like just having that documentation, having something that when the next person comes in and know exactly what was done, how, the response from the individual, etc. Having that type of documentation and communication at some level, I think is another way to move forward. But again, that has to be a continued practice and not fragmented. Right now we have a lot of fragmentation in how we service these individuals.
Fantastic.
Yeah.
Thank you.
Thank you.